It seems to me that there are three major categories we need to address. First, we need to teach ourselves and our trainees to balance the huge benefits inherent in the new science and technology in this digital age with the age-old wisdom of basing all we do on the patients themselves, and learn to incorporate science into patient-based clinical judgment. Second, we have to take cost benefit, and genuine long-term benefits into account with every patient at every level of practice. And third, we have to restructure our medical homes, reconfigure the incentives and priorities of our current healthcare system, train and restaff our medical homes, both outpatient and inpatient, focus on prevention and minimizing the costs of our care, and plow the savings back into our practices in order to empower them to optimize the health of all patients. Establishing balance in patient care is really important. All the new science, technology, and digital communications we're being offered create remarkable opportunities for the advancement of medical care. We want to put them into practice immediately, but it takes years to confirm the findings, perform the transitional research, and measure cost effectiveness and long-term outcomes. Then it takes more years before they are incorporated into best practice guidelines. I was taught that 80% of diagnoses could be made on the basis of history and physical exam. Probably many of you were too. This is still not so far wrong in terms of acquiring the knowledge we need to know in order to help a specific patient's body heal. When students and residents first come into a new service, as all of you see if you're attending, their supervisors focus on teaching them the new technologies, the lab ordering systems, the note and discharge summary documentation, the way to order consults and retrieve lab studies and x-rays. Much more emphasis is placed on these tasks than on the thinking processes they will need to use to evaluate and treat the new types of patients on that particular service. As attendings, we need to redirect some of their attention away from their computers to help them make as great a cognitive shift as a technical one, to prepare them for treating their patients, not just the test results. We also need to take cost benefit, and establish long-term outcome measures into account at every step of our practices. We order too many tests and procedures for a number of reasons. Uncertainty of clinical understanding, academic or personal curiosity, fear of not knowing or doing the right thing, practice incentives or disincentives, money, or perceived community expectation and standard practice. My use of the word daring to practice low-cost medicine in a high-tech era clearly rang true. Many people pointed out in response to the perspective that it does take courage not to order lots of tests, consults, and procedures for a variety of reasons. First, we are by nature intensely risk-averse. We don't want anything to go wrong for our patients. We want to know everything that might be relevant. We feel that doing everything is the best practice and the best way to prevent harm. We test to explore and reassure ourselves, and in some cases the patient and the family, instead of trusting our own clinical judgment, ordering no or only obviously necessary tests and interventions, watching our patients, giving them signs and symptoms to watch for when we educate them, and seeing them again in a number of hours, days, or months. We need to teach our students and our residents the subtleties of differential diagnosis that focus on the likely, how to use history and physical exam to clarify probability before we roar off chasing zebras. Our residents and students do tend to chase zebras right out of the starting gate because the tests are there and they want to show us that they've thought of everything and covered every base. We need to give them our permission, instruct them even, to focus on common conditions first, uncommon presentations of common things next, and only when the likely causes seem unlikely should we focus on the uncommon conditions. A doctor from Belgium noted, this has indeed high consequences, and not only in the U.S., on costs and quality of medicine, and it keeps young doctors from becoming good and reasonable physicians. In primary and urgent care practice, I urge residents to order almost no studies year to year. One of my respondents wrote, I talk people out of CT and MRI scans all the time. They appreciate being set free from the lunacy that has overtaken the practice of medicine. If a child has pneumonia by history and physical, treat it only if it looks bacterial. And watch. In hospitalized patients, I urge residents to be disciplined and to decide when the most informative time would be to do a test. It's a matter of pride not to repeat them, if at all possible. Our specialist consultants are in the same bind we are, perhaps worse. They seem to feel required to address every possible diagnosis our patient might have. One ID specialist wrote, "Nowhere in medicine is the pressure to overtreat more evident than in the area of infectious diseases. The development of practice guidelines, which have been developed in the spirit of zero tolerance for failure, is forcing us to leave no stone unturned and to overtreat. There's no room for watch and see." These are certainly not best practice guidelines, and they need to be reframed. We need to build a universal medical home system, inpatient and outpatient. A fully functional outpatient and inpatient medical home should be the centerpiece of high-quality, comprehensive, cost-effective, patient-centered care. This is where all the scientific and technological advances we've been discussing are blended together with our clinical judgment to the greatest advantage, where the benefits of such a system are most obvious. The focus of all efforts in medical homes is on the patients at the center. It provides the incentive to practice the best possible medicine at the lowest possible cost, since all the gains should come back to profit the patients and the operation of the center itself, and to make as high-functioning, coordinated, responsible, and effective as possible. At this moment, though, we don't have anywhere near enough doctors, nurses, or other personnel to offer medical homes to all patients who need them. The shortage of specialists and generalists has been recognized for some time by the federal government, and a multi-billion-dollar new initiative has just been announced to recruit and train new primary care providers. However, the way we're training residents, at least in pediatrics, offers them disproportionately little outpatient training, since their rotations are too often driven by the service needs of the medical center and not by appropriate educational needs. In addition to physicians, though, we need to develop and train whole new categories of health professionals to work with us. We've struggled to extend the old roles into the new paradigms, but now realizing that we need to make fundamental changes. Medical homes need clinicians with various sorts of training. Call them what you will: nurses, patient care coordinators, and support staff. For decades, I've had the pleasure of working with a wide variety of trainees, clinicians, and health practice professionals. For instance, I often have community health undergraduate students working with me in the clinic. It's a wonderful way for them to learn medicine while assisting my practice. They join me with patients, enter the visit data into our EMR, and retrieve information for me. This is an emerging profession called scribes. I have worked with primary care nurses who know my patients as well as I do, and could assist them and me with almost every element of practice. Our patient care coordinator is one of the most important team members. Our social workers not only help with family problems, but coordinate much of our mental health care. For a decade, I've worked with lawyers from the Medical Legal Partnership to advocate for our patients' legal needs. I've often worked for decades with nurse practitioners and know that they do many things better than I can. And just the way residents know more than I do, and medical students can teach me the most current science. We all need each other and should not see ourselves as competitors. Just as we should be partnering with lawyers to solve the huge malpractice challenges, we need to be working with nurses and many other health professional administrations to solve the country's massive staffing and personnel shortages. We should be welcoming and eager to partner with them so that each of us can be using our knowledge and training most effectively and be more satisfied in our clinical roles, unless you're totally happy with the balance now, which I doubt. This is not simply an issue of efficiency or financial resources or the national economy. It's the future of quality health care. We need to be advocates for change in the larger system. I'm hoping that a new health care reform will create over the next few years, will dismantle the structural and economic constraints that we currently practice under. You and I need to take and advocate for change in the healthcare system. We're actually at a time when this can happen. Massachusetts is designing its new healthcare system, and you and I need to be in there with our administrators, our public healthcare colleagues, our lawyers, and our legislators to redesign the incentives and the disincentives built into this crazy pay-for-test, pay-for-procedure, and document-all-day-long insurance system. We lost most of the last rounds because we, the healthcare providers who knew what our patients needed, felt either powerless or disinterested. We were reluctant to get involved. But the health plans and insurance companies, with their profit-driven priorities, forged ahead and set up systems and regulations destined, and subsequently proven, to produce more expensive, less effective care. And we all whined. As long as the profits generated in the business of healthcare are directed into the pockets of corporate investors and administration, the costs of healthcare at every step, from the costs of medications and fees for testing, imaging, and procedures, will continue to surge. Profit simply creates too many conflicts of interest to allow frugal practice. The incentives are all backwards. If a profit motive must exist anywhere, the money created needs to flow back into improved patient care. Otherwise, we will bankrupt the U.S. healthcare system, which you seem to be well on the way to doing. You and I have a huge responsibility as clinicians. Some of the most basic day-to-day problems are ones that only we can change. We have to swallow our pride and work with others who can help us. We all want to be the best doctors in the world for our patients, but we're obviously failing in the current system. There was a well-known creature in our house as our children were growing up, named, not me, not me. It is us. If the well-being of our patients is really our top priority, then we are the people who must make these changes through our own day-to-day practices. If we don't, someone else will make them for us, because the country can't go on like this for long. And then none of us will be happy. I do a lot of legislative healthcare advocacy for children here in Massachusetts. And it's obvious that I'm listened to because I advocate for my patients' needs first, and then my own needs second. I tend to lead with, this is what needs to change for my patients. And then, in order for me to accomplish this in practice, the system needs to enable me in these ways. Legislators did sit up and pay attention when I published my perspective because I was able to point out to them how changing incentives in the crazy fee-for-service system in place now could change the face of healthcare financing.